Good morning, everyone, and thank you for joining the Clallam EDC Coffee Chat, Coffee with Colleen. It's a lovely October morning, and we have one of our leaders of Clallam County and Port Angeles on with us today, Dr. Michael Maxwell, joining us. He's going to talk about what's happening at the North Olympic Healthcare Network and what some of the implications are from the actions taken at the federal level, which are not necessarily going to be good for the healthcare industry across our area. But we all need to know about it and really appreciate all he does. NOHN is just such an incredible organization. And I think most of you know, used to be a for-profit, and it was his brainchild to turn that into a nonprofit that then was able to get additional federal support for our community, especially in the times where it was next to impossible to get a primary care physician. So, Mike, Dr. Maxwell, thank you for joining us. Very quickly, if you'll keep yourself on mute so we don't pick up background noises. If you want to ask a question, either put it in the chat and I'll ask it, or alternatively, please raise your hand, virtual hand, and you can ask Mike a question. So with that, Mike, good morning. Thank you, and take it away.
Good morning. Thanks, Colleen, and thanks everyone for being here. When Mitch asked if I would be willing to do another presentation, I thought, didn't I just do one? Do I have anything new to talk about? And there are a few new updates. I look back, it was actually April of 24, and it was just after we had opened one of our sites. And I thought, yeah, there's something to fill in. And then luckily, President Trump gave us a nice, big, beautiful bill to talk about. I will, as Colleen mentioned, touch on that because that really is going to have some impact, as Colleen mentioned. And I think it's important for the community to know about this and kind of brace for what's coming. So with that, I am going to start. Let me share my screen. And click the right buttons. And I believe you are seeing my presentation. Is that correct?
Yes, looks great.
Wonderful. All right. So yes, as Colleen mentioned, I'm going to give some updates, and she already gave a nice little encapsulation of a little history, but I'm going to, for those of you who've been on the call and heard my past presentations, I'm going to recap a bit of that just because we're adult learners, and I think it's helpful for people to understand what we are and how we got here. So I'm going to give another brief overview of us and health centers in general, just to frame things in context. So I would like to start with our mission, which really does nicely encapsulate what we're all about. And it is, we're here to provide patient-centered, quality-driven, whole-person healthcare services that are accessible to everyone in the community. And each one of those pieces of that phrase carries a lot of meaning for us, and we really do take each part of that very seriously. I do want to talk a bit about how we got here. As Colleen mentioned, we didn't start out this way. We are a 501c3 and not-for-profit FQHC, Federally Qualified Health Center. But we did not start out that way. We were initially back in 1979, started as a different entity down in medicine in Port Angeles, which was a private practice primary care group. I joined the group in 1991. By 2013, we were struggling as a community to maintain access to healthcare, to primary care, for a variety of reasons. And for us, one of the recognitions was that the model in medicine that had been successful for so long really was just not durable for the future, the way healthcare was moving in this country. The private practice model was not sustainable, and was difficult to get new graduates to want to come to rural community and invest in a practice or run a business. They wanted to focus on taking care of patients. And so that's when we made the decision to make a change from our private practice model into something else, and that was a change to North Olympic Healthcare Network, and that was a process which was lengthy, it was arduous, and frankly, there's a little bit of good luck and timing. These grants, what are called new access point grants from the Health Resources Service Administration, or HRSA, they come available only periodically. And through the Affordable Care Act, there was some additional funding to expand the health center model into communities that were struggling with access to care. So we made the application. We were one of about 2,000 applicants for these grants, and we were one of 164 successful applicants across the country. And so we were reborn in 2015 as North Olympic Healthcare Network. And we really did this because we thought a change in this model was the best way to ensure that this community would have access to comprehensive primary health care going forward. So what exactly is a community health center? So you'll hear these terms FQHC, or Federally Qualified Health Center, and CHC, or Community Health Center. They refer to the same entities. They are the same thing. The FQHC terminology is often used in reimbursement models references. Community health center is the clinical model. That's my preferred, but you may hear me go back and forth. So if you see one thing, it means both. In a nutshell, FQHCs are nonprofit, community-based, and patient-directed organizations that serve, and this is key, populations with limited access to healthcare, and that certainly describes Clallam County, particularly back in 2013. The legislation that underlies the health center program was signed by President Johnson back in 1964, and was actually part of the civil rights legislation that was happening at that time. And it was developed to address medically underserved areas, both rural and urban. The first health centers, there were two of them. One was in inner city Boston, and the other one was in rural Mississippi. And that was how the humble beginnings of the health center program. I will get into this a little bit more later, but really health centers are focused on giving comprehensive and integrated primary health care services. And I'll touch more on that at a later slide. From those two health centers, there's been progressive expansion of the program because of its successful impact. There's now over 1,400 health centers in all 50 states. Known as the newest of the 28 in Washington State. So we're 10 years old, and we are the newest kid on the block. Collectively, the health center program as a system is the largest in the country. It serves collectively 32.5 million people. Actually, 1 in 10 Americans are cared for in a health center. It includes over 9 million kids and almost 500,000 veterans. The health center program is very complex, but there are 6 fundamental features which really underlie the core of what a health center program is all about. As I mentioned, it focuses on serving areas of high medical need. So in order for a health center to exist, it has to prove it's in an area where there is a high degree of need for additional medical access. So there's something called health professional service, health professionals, shortage area, HPSA, or the medically underserved area or population. So there's a way of scoring communities about their access to services, and the higher the score, the lower the access. And Clallam has traditionally had a very high HPSA score. A key feature for health centers at the core of the philosophy is that HRSA believes that the healthcare should be responsive to patients' needs from the patient perspective. And so one of the requirements is that all health centers are governed by patients, by consumers of those healthcare services at that health center. All health centers have a board that's comprised, must be a majority of patient consumers of patients. So at NOHN, we have 11 board members, and 9 of them are patients. The other 2 are just waiting for their current providers to retire before they become patients. But that is a core tenet of the health center program. Health centers focus on comprehensive and integrated care. So comprehensive, where all your primary healthcare needs can be obtained in one place. So your primary care, pregnancy or obstetrical care, pediatrics, behavioral health, vision services, pharmacy, all these major primary services are all in one place and integrated. That means that they are not just silos, but they're sharing records or sharing communication between providers, sharing information to make sure that the care is coordinated and it's actually more efficient. That there's less risk for things dropping through the cracks. And actually, it's more cost effective. The data shows that health care obtained in a health center is 24% less costly than health care taken elsewhere because there's just more efficiencies. Another very important element of the health center program is that nobody gets turned away. So we will see anybody regardless of their ability to pay. We will reduce the fees all the way down to zero if they qualify based upon household size and income. So if you hear someone say, I can't afford to see the doctor, that's not true in a health center. We will make sure the cost is not a barrier to receiving our services. Unlike private practice, which is sort of focused inwardly inside the four walls, taking care of business within the four walls, health centers are oriented.
What? Sorry about that.
Can you hear me now? I can't hear you now, Colleen. The way you tell me I'm talking too much, I should shut up. Okay, I will proceed as if people can hear me.
I'm sorry. I meant to mute myself and I muted you.
Oh, it's probably just a Freudian slip, Colleen. Yeah. Yeah, so we're collaborative. We sort of work with others in the community to identify needs and work together to address those needs. Then lastly, but not least, is we are held to high levels of accountability. There are 320 separate regulations that we have to be in compliance with at all times, or they can revoke our designation. We have to supply to HRSA data on a regular basis regarding our costs, our service utilization, staffing, clinical outcomes, to just name a few. And if we aren't meeting standards, then they can revoke our designation. So they take it very seriously. On top of that, every 3 years, we're subject to a site visit by HRSA. I call it the administrative colonoscopy. They come on site and they go through every nook and cranny to make sure that we have all the proper policies and procedures in place and are following them. We've been through 3 of them already, and we are actually due for one in the next couple of months. That's assuming the government reopens. If they don't, then I guess there's no site visit, so there's an upside. But my hair was not this color when we started, and this accountability is a large contributor to that change. So what's the end result of all that work? What has it been worth it? And thinking back to the whole reason we did this was to try and make sure that we had more primary care providers in our community. This has been a success. Since becoming a health center, we've been able to bring 19 new physicians to the community, primary care physicians, and 15 nurse practitioners or physician assistants. With that additional access, there have been over 16,000 new patients. Those were ones previously who were having trouble accessing a medical home. We now have over 19,000 active patients and did over 68,000 visits in 2024. About a third of our patients are insured through Medicaid. Representative of our community, 35% are on Medicare, 30% are commercial, and the rest are uninsured, which has currently been a relatively small amount, but that's about to change, I fear. One thing to note on the commercial is that About 65% of those with commercial plans are actually getting that through the Affordable Care Act subsidies, the marketplace subsidies. And as we'll talk about more, that is under immediate threat. Colleen, you had a question?
Yeah, it was about that as well. But comparing your percentages to what OMC does, that we all know is in a lot of financial trouble at this point, theirs is higher on Medicare, right? And a bit lower on Medicaid. Why do you
Yeah,
think your splits are different than theirs?
I think that there's a distinction between OMC and OMP. So
Okay.
OMP is the outpatient, similar to what we do, taking outpatient care. And I will bet you I've not talked to OMC about this, but I would suspect that their proportions are probably on the outpatient side, probably very close to this. Those that end up getting sicker are usually those who are older. With more, and so there's going to be more Medicare, so it's going to be a higher proportion end up in the hospital per se. So the
Okay.
inpatient proportions look a little different, but that's my suspicion.
Got it.
As a safety net provider, we do slide our fees down all the way to zero for those who qualify, and then we've been able to do a lot of new services and programs since becoming a health center. And I'm going to talk about those a little bit now, just kind of give a little timeline of our service expansion, our growth. So
Do
we
you
have
have a wait list now today for patients that want to become members of
yeah,
NOHN?
we
Yeah.
do, and it grows and shrinks as we bring in new providers. They have more capacity, so we can work that list down faster. But then it builds back up, and the rate of intake slows down as those panels fill up. And it's one of the struggles that we work through, is how you balance meeting all that need as fast as it generates, and we start running out of space and running out of ability to support that much. So it is an ongoing challenge, but we do have we just have one new provider start. We have two more, or two started and two more starting within the next 2 months. So that should help kind of work through that backlog for now.
Got it. Thanks.
You bet. So we had our NOHN just celebrated our 10-year anniversary. It was September 1st, 2015 is when we officially activated our new Access Point grant. And so we're 10 years old. We're almost potty trained. One of the first things we did after becoming a health center, one of the first programs that started or expanded was medication assisted treatment for opioid use disorder. You think back 10 years ago, and it's still an issue now, but it was particularly a crisis in rural America and certainly in Cloud County. Opioid use disorder was just a huge issue. We had the highest overdose deaths in the state. And so there was a real urgency to try and address this. Our physicians have been doing this service for years and years, and we used a collaborative nurse care model to expand our capacity to see more patients and help get this life-saving treatment out to more people. And so that was one of the first programs we started. The following year, we started our rural residency training program, family medicine resident training in collaboration with Swedish and OMC. This was actually a big driver for why we wanted to pursue the health center model, because it's a perfect environment for establishing a residency. The idea was for the long-term workforce pipeline, if you train a physician in the community, they're more likely to stay in that community. And in fact, that's been the case. So I think we graduated our 6th or 7th cohort of physicians. I think collectively there might be 21 residents, and 6 have stayed in the community. So that's pretty good return. 4 have stayed with NOHN. 1 went to Jamestown, and 1 actually next year is going to OMP. So it's we always emphasize this is not to necessarily make physicians just for NOHN, it's for the community. And so we're happy to see them go anywhere and stay in the community. We expanded our behavioral health program later that year, bringing on counselors and psychiatric providers to address the epidemic of behavioral health and mental health conditions. We started to outgrow our footprint, so we had to acquire some space to lease at our expanded services building over on First Street. And that allowed us to spread our wings a bit. We also started clinical pharmacy at that time to have pharmacists work alongside our providers for helping manage complex medical needs. We had to get some administrative space next door at Old Cowboy Country to give us a little more room, and that made us allow us to have space for opening a dental clinic. And I do want to do a shout out to Representative Theringer, who played a big role in helping us obtain a state grant to help get the thing started. It's a big deal for the community. This was the first new dental access in Port Angeles for adults with Medicaid in nearly a decade. So prior to opening this clinic, the majority of adult dental care was done in the ER, which is not the best place. And so it's been we have almost 4,000 visits a year. We really, talking with Daryl OMC, it was had a huge impact on the volume of dental care that we're doing in the ER. So we were really pleased to be able to do this, and are grateful to Steve for helping us get this started. We achieved patient-centered medical home status through the National Committee for Quality Assurance, level 3 designation, which is on the par with Mayo Clinic and Kaiser. It's just a reflection of really putting into practice patient-centered practices and procedures that are focused on quality. This little thing happened somewhere about that time with COVID, and that really threw everyone for a loop, especially us in healthcare. I won't recount or relive that trauma, but one of the things that we had to do is really accelerate our ability to deliver services in a little different way. So we expanded our ability to do telehealth visits, and that did help us kind of roll with the punches during that time. We worked with the county to help with mass vaccination clinics, and it really did help jumpstart our county in getting out of the impacts of the pandemic. We were able to start a mobile health unit at that time. It was supposed to have been delivered earlier, but the pandemic delayed things. But that really helped us get out and start bringing care to places which could not, people and populations that could not access services as conveniently at our sites. And I'll talk a little bit more about that later. We spent our outreach services using that mobile clinic, and then expanded into an Eastside Health Center that I think was what was focused on my last presentation for the EDC. That allowed us to start a new service with Vision. Our newest service is outpatient pharmacies within our sites, and I'll talk about that a bit more here in just a moment. So during that time, with that growth, we went from 35 employees to over 180.
Wow.
Patients went from about 5,200 to nearly 19,000, and our visits increased substantially, almost 68,000 as of last year. So I want to highlight just a couple of these new services for us. I think I mentioned on the last time I presented that we'd opened optometry, and this really has really proven to be a really successful program for us, and a really impactful program for our patients. So Dr. Heward has been in the community since 1995, and he was one of the few who were providing vision services to patients with who are insured by Medicaid. I was actually so a little disclaimer. John was my longtime optometrist, and I was in the chairs, and he's poking around my eyes, and we were kind of talking about business, and he was mentioning just how he's lamenting just how difficult it was just to try to manage all the practice parts, the practice management, deal with insurance companies, contracting, and all that, and just wish he could just take care of patients. He says, well, would you consider? And 2 years later, he was working with NOHN, and so it was really it was a win-win, because John was really he's such a great provider, but he was just getting burned out by the parts which are not very much fun. So he started seeing patients in February 2023, and and really is service available to all known patients, including the uninsured. It's been so successful that we have been able to expand this by bringing another optometrist, Marilyn Holm. She just joined us last month, and it's just getting up to speed. So it's we're really happy to be able to expand on that. The newest service is outpatient pharmacy. So we opened up our outpatient pharmacies within our Downtown Health Center and Eastside Health Center in July 2024. And we did this because it really, for two main reasons. It had some patient care advantages. One of the things that our sliding fee program also applies to medications, so that we can, by bringing those in-house, we were able to ensure that our patients can reliably get access to lower cost medications through the sliding fee program. As a clinician, I know that the medicines don't work very well in the bottle on the shelf. So when the patients don't pick them up and don't take them, they don't work very well. And so we can, by taking down these barriers to patient accessing the information, the medications, they take them more reliable and get better clinical outcomes. Yeah, Colleen.
Yeah. How has the closure of Rite Aid in Sequim and Port Angeles affected the pharmacy situation overall? I know they have moved patients over to like QFC and Sequim. Has that been fairly seamless, or are you hearing about problems?
Well, the parts that has impacted us is we have seen with that a lot more of our patients choosing to fill the prescriptions at NOHN. And so our pharmacy directors have seen just a big uptick in just volume of people saying, well, they're using it as a good opportunity to switch their pharmacies. I have not heard, my understanding is that it's those prescriptions are being transferred to different pharmacies of the patient's choice fairly seamlessly, and so far the other pharmacies have had the capacity to take on those prescriptions.
Okay, thank you.
Another advantage for our patients when they having pharmacies in-house is that, you know, when you're in the room with your physician, they say you need this medication, let's say you have strep throat, they can stop by and pick it up at the pharmacy down the hall on the way out the door. So it saves them an extra trip, and they really like that convenience. And then to your point, Colleen, is that having pharmacies within our four walls, we can ensure access. We don't have to worry about other pharmacy closures. We can make sure that our patients get access to medications because we will have them for them. So that's another advantage. Some operational advantages is that it's has traditionally been a game of ping pong between the medical provider and the pharmacy. How many times the patient heard, well, the pharmacist says, I'm trying to get a hold of your doctor, and the doctor says, I've talked to your pharmacy, and it's going through the fax machine and phone calls and back and forth. And it's just a lot, it's clunky communication, but when you're all part of the same team, medical records, same facility, it's a lot easier to facilitate that communication, so the patient isn't left hanging as long. It's also easier to remain compliant with a bunch of the regulations, particularly around 340B when it's within our four walls, so we can address our stay compliant more easily. And then it does provide us some additional revenue, and that's important because a lot of our patient services are unreimbursed or under-reimbursed, and having this additional revenue source is critical to keeping some of these high impact but under-reimbursed or unreimbursed services available. So it plays a real important role that way. I want to touch this real briefly. I talked about collaborations earlier, and NOHN has been involved in a lot through the community since our inception. We participate in the Olympic Community of Health, which is a regional health collaborative that involves multiple sectors, multiple healthcare providers, community-based organizations, others all working together to address complex health and healthcare needs that are difficult to tackle by yourself. And NOHN has been active in collaborations through the OCH. I think the OCH is also participating in the Recompete grant, so they're helping out with that as well. Our mobile clinic, one of the first uses we had during the pandemic was to bring mobile services, health services to kids in the school district, the PA school district. Originally, it was thought that medical services would be most important, but we learned that behavioral health issues predominated, and that really characterized much of the care we gave to the mobile health unit. We are expanding now to the West End, and I'll touch on that a bit later. But the Colleen Valley School District, our outreach manager has been making inroads to the west side, and Colleen Valley School District has a lot of needs, particularly around dental, and we're working on how to help bring some of the services out there. We worked with the Port Angeles Fire Department to help expand the community paramedicine program. We actually applied for a private grant that was able to help expand the number of community paramedics in Port Angeles. It's been a really successful program on helping to address some really complex patients who were frequently visiting the ER, having uncontrolled disease, and this helped get out upstream of that and have a big impact. And we've been working with fire departments since that inception on that program. I mentioned about the mass vaccination clinics. This is kind of old news now, back in the 2021, but it did give us a nice dry run for how we can coordinate with the health department for any future public health emergencies. And this is editorial comment, but I fear on the horizon with our shift in our approach to vaccinations, we're going to be seeing a lot more public health emergencies and epidemics, and we're prepared to work with the health department to try and address those as they arise. I talked about our residency training program, collaboration with Swedish and OMC. We have the Port Angeles Food Bank does bring the mobile market to our Eastside Health Center on a regular basis. And then our newest collaboration that's sort of still in the works is working with the Clallam County Jail to bring reentry health services to their inmates who are preparing for release. Very often they have complex health needs, many around behavioral health or substance use disorder conditions, and we are working to be in the jail to work with that population, getting them treated and controlled, and then seamlessly on discharge, be right back, be able to be taken right into the outpatient care. Colleen, yeah.
Yeah, so that's great. You're taking that population on. I would think, though, it would be uncompensated care very often. And how do you pay for that?
This is a really good point. That there's an opportunity through this 1115 waiver that's happening with CMS at the state level. Has focused on jail reentry services that they're actually allowing now for Medicaid to cover reimbursing care for in the jail standing for a very narrow period of time. And so so there's a revenue stream to come with that now for the first time.
Okay. So what happens after that period, after they're released, expires? Will you try to get them on Medicaid?
Absolutely.
And then, okay.
Yep, that's the idea. Is we'll have our enrollment and outreach people work to try and reestablish their Medicaid eligibility. Now that's as I'll talk about a bit more, that's going to be much more difficult now, but that's going to be our goal, is to get them connected with re-enrollment. So I'll pivot a bit now to challenges. Workforce and staffing. When I last spoke with you all, it was really big. I mean, just coming out of the pandemic, it seemed like nobody wanted to work. I don't know where everyone was, but it was hard to find workers, especially healthcare workers. But we found in the intervening years that we're having more success in finding people who want to return to work and do this difficult work. Staff childcare continues to be an issue. For us, it not only impacts operations, but it impacts patient care. And the provider has to call out because their daycare provider is no longer available because they call out sick. Then we have to cancel a day's worth of patients. That means those patients have to delay or defer their care. So it's an important piece of the puzzle that we are really pleased to see that the Y is making a lot of efforts to move forward with their early childhood center. And so we're looking forward to having more resources in the community to address that need. Housing, I mean, I've been on multiple calls on this forum where we know that housing is just, it's a problem in every industry, for every employer, for every family, and it's the same thing for us. We have lost some employees over the years because they could not find affordable housing. I'm not sure when it's going to be fixed, but until it is, it's going to remain one of our challenges. Wage inflation is a big deal. I mean, as inflation in general persists and the cost of living goes up, there is more and more pressure for employees to try and understandably increase wages to help their staff be better positioned to deal with their rising costs. But it's a real challenge for all employers, and we're definitely feeling that. Not only in the wages, but also health insurance. Our benefits costs are skyrocketing. And you would think that, you know, we're in healthcare, we should get a break. No, we don't. Our premiums were projected to go up by 34% this year. We were able to negotiate down to about 22%, but it's still a big kick in the budget pants. It's really painful. And between wages and benefits going up and our reimbursement not, it really does add more budget pressure. Our reimbursement has been very stagnant, and it's a challenge. It's something that unfortunately is going to become even more challenging in the coming political season that we're in, and that we're going to talk about here a bit more. And that's around with changes in the political environment at federal level, because we are federally designated and have some of our funding federally. We are directly impacted by all the changes happening in DC, and you know, changes in political ideology definitely have an impact on healthcare delivery and our funding. And so that's the biggest challenge facing us right now in the immediate future, and actually facing this entire community, and well, facing the nation really. So I'm going to spend a next little bit talking about that in more detail. And I do want to emphasize, you know, my intent is not to be political, but the politics does impact policy, and which impacts our operations and everyone's healthcare. So there is some politics woven throughout here, because that's reality. So shortly after the Trump administration started in January, almost within the first week, there were a flurry of executive orders that some of them I spent all day talking about them, about how they impacted us, but one of them established DOGE, and almost within the first week of the administration, DOGE was interfering with the outflow of grant dollars, and so both grant dollars and money leaving CMS, so Medicare and Medicaid. So there were big disruptions to just barriers erected to being able to draw down grant dollars or receive federal reimbursements. Those were very disruptive. They still periodically add additional barriers. I think my CFO is on this call and has to wrestle with getting our grant draws with ever escalating series of barriers. And it's a real challenge. On top of that, DOGE cut staffing to HHS by 25%. So CMS and HRSA, which are a big part of our lives, there's just less of them there. And so getting a response from them, just dealing with all the bureaucratic hurdles we have to get through are just a lot more difficult, because there's just fewer people there to respond. The installation of RFK Jr. into the HHS secretary position has been really concerning for me as a clinician, just to kind of watch the erosion of science based policy, and it's really quite frightening, and I'm just afraid that we're losing our sense about what actually real science is, and the fact that it's happening at a federal level. We've been able to lose confidence in the stalwarts of scientific touchstones, the CDC, the NIH, ACIP around immunizations. They just can't be trusted because they're all politicized and not based upon science. It's based upon ideology. The rise in anti-vaccination views are, we're going to really see, we're already starting to see with measles, but we will be seeing more whooping cough, diphtheria, these things which we, in my career, were just sort of more historical things, are coming back. And there's a critical point when the population becomes not immune to these things that we take it for granted, where it sets off like a firestorm. And so I think we need to brace for some really. We thought COVID was disruptive. Just wait for this cascade of all these preventable infectious diseases coming back over the next few years. And then for us, because the federal budget, the federal government has had a hard time passing a budget. There was HRSA, which gets a federal appropriation, wasn't sure how they were going to be funded. And so we actually had a new access point grant application in before the election that was very competitive for being able to establish a site out in Forks to bring services to the West End, because we know there's quite a bit of need out there. And we had a very competitive application, and we're all ready to proceed. But after the election, they put a hold on all grants and changed their ideology. It didn't necessarily align with administrative priorities, and so it's not. They said don't expect any funding. So basically the funds they were hoping to happen to be appropriated did not come through, and so this grant expansion was canceled. So that had real impact on our county. And then, of course, the big one is the One Big Beautiful Bill Act, or HR1. There's nothing beautiful about this bill when it comes to healthcare, and that's just plain and simple. And I think we need to understand that. The bill passed the Senate narrowly. It's a tiebreaker. The Vice President had passed the tie-breaking vote, and it barely passed the House. That was signed into law on July 4th. And the upshot is that its goal was to extend $4.5 trillion in tax cuts that go quite proportionally more to the highest income earners, and by funding that by cutting deeply into the healthcare safety net funding by $1.2 trillion. That affects food stamps, health insurance through Medicaid, and the Affordable Care Act insurance subsidies. It also did that by creating another $3.4 trillion in debt, which has some sequestration impacts on Medicare funding. So it's a bad news from multiple directions for healthcare funding. The challenge with this is that they were able to pass this through with enough political cover by characterizing these Medicaid cuts as addressing fraud, waste, and abuse. That has been a very effective mantra that the Republicans had been able to use to push some things through and get some support from their constituents. Because it makes sense, right? Who would support fraud, waste, and abuse? The trouble is that it's a complete misdirection and mischaracterization of what actually how Medicaid is administered. The picture that they want to paint is that the average Medicare or Medicaid recipient is a lazy beer drinking guy sitting on his couch playing video games and refusing to work. And sure, they're probably out there, but that's not the majority of Medicaid recipients. In fact, most are working. They're actually working multiple jobs, multiple low-wage jobs, and their employers can't afford to give them health insurance, so they get it from the state through Medicaid, a state federal partnership, which is Medicaid. The Republicans and Trump tried to kill the Affordable Care Act earlier and were unsuccessful. But this is actually a way to do it through the back door. They essentially have revoked all the major provisions of the ACA piece by piece, and so under the radar, because they know the ACA was Obamacare is actually quite popular in both red and blue states. They will characterize this as work requirements, or what they call euphemistically community engagement, saying it seems very reasonable that if you want to be eligible for Medicaid, you got to be working, or you got to be looking for work, or have a good excuse not to. And the trouble is it's really a smokescreen, because in Washington State, actually 92% of the people on Medicaid are already working. But like I said, working multiple jobs. It's just that the administrative barriers, the burdens that are proposed that the state needs to implement every 6 months for someone to prove that they're working and prove that they're eligible to maintain that insurance, they're so onerous that people are projected to be dropping off permanently or recurrently. So it's hard to maintain that continuous insurance coverage. And the feds haven't completely outlined all of the requirements for these work requirement verifications, but what we've seen so far are they're quite onerous. In fact, in Arkansas, they did this, and it was so expensive for the state. The state actually ended up losing more money through the administrative costs of trying to constantly verify eligibility. And for when patients lose that eligibility, they're still getting sick. They go to the ER, they're uncovered, and costing them more that way. So it's really an unfortunate characterization.
So Mike, if someone's on disability, are they required to do these work proof of employment?
No, there's some exemptions, and disability is one of them, but you actually have to prove it every 6 months, even though you have a chronic illness. And if you don't get the right documentation in the right place at the right time, then you're dropped from the rolls, and it takes you a while to get back on. So this is constant churn, which is disruptive.
Of these cuts to SNAP, and anyway, you had them listed there, what do you expect to be the biggest impact for our local communities?
I'm going to get to that here in a few slides here, but it's going to be all the above, honestly, Colleen. But I'll touch on that here in the next couple of slides.
Okay, thank you.
You bet. And as I mentioned, this is a functional repeal. This one big beautiful bill is a functional repeal of the ACA. What they couldn't repeal before, they just kind of did it through the back door. And the trouble is that ironically, there are more Medicaid recipients in the red states. And the trouble is that most people don't know that they're supporting things that are against their own interest, because they don't understand there's a lot of misdirection. We're expecting the uninsured rates to increase back to the way they were back in 2013, go from 18% to more than 35%, so about 16 million more uninsured. About 5.5 million people are going to lose Medicaid coverage in Washington. That's upwards of 300,000 people are going to lose their Medicaid coverage. For NOHN, we had an analysis done that projecting between 50 and 65% of our patients with Medicaid or with commercial insurance, the ACA, are going to become uninsured. That's huge, and so that's going to eat into our revenue substantially. Collectively, it was projected that about $7 billion a year of costs from uncompensated care are going to be experienced by CHCs across the country. This is going to lead about 41% of CHC sites to close over the next 3 years, and then upwards of 50% reduction in FTE as a result of that, when the full impact of these things hit. Now, the problem is that these hits are delayed. A little bit politically cynically, those that voted for this know it's really bad. They know it's bad. They know it stinks for their constituents, and they know that their constituents are going to be hit hard, even the red states. So they delayed the impacts on Medicaid until after the midterm elections, so that because they know if these things were happening right now, they would not be able to retain power in Congress. So they wait till after the midterm elections to have these Medicaid provisions take full effect, so that they are not impacted at midterms. They know that if there's a change in control at the midterms, there could be some potential that to walk back some of these changes. The budget deficit of 3.5 trillion is likely to trigger automatic sequestration, which means that there will be a 4% cut to Medicare reimbursement across the board unless Congress takes specific action. So that means it's not just Medicaid, Medicare is going to be impacted negatively as well as a result of this bill. It's going to hit the state budget big time. I'm sure Steve is losing sleep at night along with the rest of the legislature trying to figure out exactly what's going to happen. No one knows for sure because trying to project what the actual impact of these work requirements and eligibility verifications are going to be. It's hard to model, but potentially could be in the billions of dollars for the state. And Steve could probably talk more about that. He will have more knowledge than I will. We're trying to work with the state to let them know, this is coming, and so they'll have limited options to address this loss of federal revenue besides cutting eligibility, reducing services, or reducing reimbursement. I mean, there's unless they can raise new revenue, and there's not often a lot of appetite for that. So it's a real tough pickle that the state budget is in as a result. And then this current federal shutdown that we're experiencing now is tied to these Medicaid cuts. So the Democratic budgets that have been proposed want to preserve these ACA subsidies and reinstate Medicaid coverage, and the Republicans don't want to do that. So it's this game of chicken. Who's responsible for the shutdown? The Democrats are basically drawing a line in the sand, saying this is what has just happened with this bill to healthcare is it's unconscionable and it's unsustainable. It's going to be really detrimental to the country. So they're putting a line in the sand, and we'll see if who budges to see if we can get some of this coverage back for Americans. The thing to remember is that uninsured people don't stop getting sick. Just because you're uninsured doesn't mean you don't get sick or hurt. You will probably defer management, of your chronic illnesses because you're not going to go if you're not insured. You become sicker. You don't pursue preventive care, so you end up ending up with preventable conditions, and then ironically you end up getting illnesses that keep you from working, and it keeps you from being able to regain or retain eligibility. And then if you have a contagious disease and don't get it treated or evaluated, then you end up spreading to others, and you have another epidemic on your hands. Ultimate outcome is that there's a greater disease burden on the population. There's greater cost to the health system. There's more unreimbursed care, and there's a more financial stress to providers and hospitals. And you're going to see closures and reductions in service as a result of this. The thing to remember is that when you decrease healthcare funding in any part of the healthcare ecosystem, it just doesn't impact that one set of people. It impacts everybody. This situation is going to impact our rural hospitals. So OMC is going to be impacted by this. It's going to certainly impact us, and PBH is going to be impacted as well. We're going to have fewer resources to support staff and services, which means that, if depending on how badly this hits, if we don't have the money to pay staff, you can't retain as many staff, or maintain all the services that you've been providing, and you may have to close some departments or delivery sites, depending on how badly this hits. So the thing to remember about this is that this bill reduces healthcare access to everyone, not just those on Medicaid. Because if I or OMC or PBH don't have the resources any longer, because I don't have the financial resources to retain staff and services, then you as an uninsured patient or a Medicare patient can't access services either. So you're going to be having longer wait times, you're going to travel longer for services, and some services are going to be flat out unavailable. And we're going to have worse healthcare outcomes as a result. So it's just, there's not a whole lot that we can do. I mean, this bill got passed, and so we just have to brace ourselves and adjust our expectations. And it's going to feel like, well, nothing's happening yet. But as I said, the big things are going to hit after the next midterms. That's when they timed for this bomb to go off. But I think helping people understand that this time bomb is ticking, and if there's if this is important to you, then you say, maybe you want to impact control of the House or Senate for midterms, so that there can actually maybe roll back some of this healthcare catastrophe that just got laid in our laps. And we need to support policies that ensure broad access to healthcare, and that's not what this bill does. But we need to, if this is important, if this scares you, and it should, then the only way to change this is at the ballot box. So I got about 8 minutes left. I'm going to quickly run through a few things, at least sometimes with questions. I just want to talk about what's on our horizon. So we've been able to successfully recruit, and we're nearly fully staffed. We're still looking for an OB provider and some behavioral health providers, but we are not going to be doing a lot of hiring. Probably a lot of employers doing the same thing in the environment of the uncertainties brought by HR1. We don't, for the same reason, plan on doing major expansion of sites or services, because we don't know what our revenue will be or our staffing. They're really frightening times on the horizon. We're going to try and intensify our outreach enrollment efforts to maximize people's access to insurance. We've been working very hard to try and connect with our patients, to get them reconnected with this state, to get re-enrolled with Medicaid. But those administrative barriers can be really onerous, and it's going to be chaos. We're going to try and expand our mobile services to the West End. Since we can't do our fixed site like we planned, we're trying to be more present through our mobile unit, but that has limitations. We're going to graduate more family medicine residents, join the community anywhere. And the last thing, something that got everyone's attention, there's going to be a leadership transition here at NOHN. So just a little bit of history. So this is the original site of the predecessor for Family Medicine Port Angeles on 16th and C Streets. This is Clown Family Medical back in 1979. That's actually where I came as a resident to kind of check the place out. When I joined in 1991, we outgrew that house and built this place on 8th and Cherry. That I think the hospital owns this building now. And so yeah, I joined in 1991, and there's this child in the back that was the new partner that came at that time to join. Well, that's a different ribbon cutting. Some 25 years later was the opening of NOHN. Congressman Kilmer was there to help kick us off. So we've been able to expand all of our sites and services since then. So there's been a lot of activity. So I went from this youngster, and this is a picture of me the other day when I woke up. So something happened in the meantime, and it's been 30 years of practice and 10 years of dealing with HRSA and wearing the target as CEO, and 64 plus years of life that have all sort of taken their toll. And it feels really bad to retire at this point, but I told the board this years ago before Trump was elected, but my wife would kill me if I changed my mind. And so I'm moving forward with my plans to retire in May. So the end of May will be my last day here. I'm working with the board. They're doing a robust national search process to really get a good pool of candidates. And we're going to, we're preparing our staff and engaging them in that plans for transition. The board is really just an excellent board. They're smart. They're mission committed, and they really do believe what we do. And I know they'll make a good selection. And so even though this may be how I feel most days, my plan is to sprint to the finish line, and I'll be filled with nothing but gratitude and fulfillment for having the opportunity to be part of this community and part of this organization. So with that, I will shut up and answer any questions in the time is left.
Well, thank you so much for that amazing presentation, Dr. Maxwell. Yeah, we've been lucky to have you in our community, no doubt. Representative Theringer, is there anything you wanted to add from a state level before we sign off? Hope you're on mute.
No, I think Mike did a great job. We do have, I mean, overall, our state budget, we have about a $16 billion exposure with Medicaid and Medicare, Medicaid mainly, because that's what we match. But I think in the near term, we're going to have to spend money on setting up the database to do the work requirement that Mike was talking about, which really has no benefit. That money would be better spent on care itself, but it's a requirement. And then I think over the near term, say the rest of this biennium, next biennium, we're probably looking at about a $2 billion hit from these changes. Depending, what happens going forward. But it's just the question is do we as a nation feel we should provide health care? Do we feel we have that moral imperative, or do we just let people just dangle? Because people are going to get sick no matter what. So then do we have a system that deals with that and supports them and makes them well, or do we let them kind of flounder in a neoliberal world where it's just, competition? We're the only industrial country, as people know, that does not have a subsidized healthcare system for everyone. So it's kind of crazy.
Yes.
All right. Well, thank you so much for your presentation, Dr. Maxwell. It is 9:03, so we're going to call it a morning. Your team does an exceptional job and is an important component of our healthcare system in Clallam County. And we thank you for your diligent work that you all do every day. So, and I know your retirement was coming, and it's well deserved. And I know your board is working hard on finding a replacement that won't be able to live up to the love and standards that you've provided over the years. I see you as the hometown doc that everybody appreciates and loves. So it'll be a big loss, but so well deserved. And we thank you.
Colleen. Thank you very much for saying so.
Yeah. Thanks very much, everyone. Have a great day.
Bye-bye.
Bye-bye.